Thank you very much, Malaraman. I would like to thank the College of Ophthalmologists of Sri Lanka for inviting me to do this talk. So this is not actually, this is not something that I do. I don't do cyclo refractions at all. So I'm not going to tell you how to do it. I can't teach something that I don't do. But I would rather speak few things, what we as surgeons, what we expect from you when you do cycloplegic refractions, and where we can merge our knowledge, our practices to manage the patient in proper way. So this is a very simple talk, not like Aruna's hi-fi talk, and this is your daily practice. So in children, it's essential to do cycloplegic refraction. So it's always cyclo, it's not, so auto refraction is not enough in children. Right? So why do we need cycloplegic refraction? Because when we do any refraction, we have to give the correction to the static power of the eye. And we should disregard the accommodative power. So what is static power? That is the innate power of the eye, which is the combined power of the cornea and the lens, which is the primary force of bending light onto the retina or wherever it focuses. So as you know, accommodative power is generated by the tone of the ciliary body and the ability of the ciliary muscle to alter the curvature of the crystalline lens. So it's a variable power, and if you and it's a compounding factor when you do your refractions. So you have to remove this compounding factor and find out the correct static or the proper power of the eye to give to prescribe or not to prescribe. Yeah. So cycloplegic drugs inhibit the action of the ciliary muscle. So the lens, the curvature of the lens stays the same when you are doing the cycloplegic, when you are doing the refraction. So we use certain drugs to paralyze or weaken the ciliary body muscle. With that help, we keep the thickness of the lens, throughout the refraction as same. So why cyclo refraction is needed? Because of the near reflex, particularly in children. Right? What they do is they accommodate, and their accommodative powers, the amplitude of accommodation are very strong, particularly in younger children, and they won't cooperate for your retinoscopy or your even for auto. They won't cooperate enough for you to get proper readings. So if they accommodate, what happens is accommodation is accompanied by pupillary convergence is accompanied by accommodation and pupillary constriction, which is the triad of near reflex. So patient will invariably look at the retinoscopy light. Then accommodation comes, and you won't be able to get a proper retinoscopy reading. So when would you consider doing cycloplegic refractions? Of course, in younger children, it is a must. So remember, it's not appropriate to give glasses, prescribed glasses, just based on subjective refraction in younger children. So when you want to bring out the real refractive error of a patient, because of the accommodative reflex, patient can develop pseudomyopia. And you have to, when you want to rule out pseudomyopia, of course, in cases of accommodative spasms, this is very common in children, particularly children who are doing this grade 5 scholarship. That age group, this is very, very common to present like pseudomyopia. In isotrope cases, it's very, very helpful to find out latent hypermetropia, because correcting hypermetropia is the basic principle in managing certain types of esotropia. So in uncooperative patient, you must consider that all children are uncooperative, right? But there are all the children, like 15-year-old child with Down syndrome. So that is an uncooperative, proper uncooperative patient. And things will be complicated by the child having a squint, child may be esotrope, and child may be having a bit of cataract. So you are not able to do a proper subjective or auto refraction in this patient. So you must dilate and do a cycloplegic refraction, and you can prescribe depending on your retinoscopy findings. You don't have to do. You don't have to go through a subjective refraction in all the patients. So in doubtful cases, of course, you can do cycloplegic refraction. There are kids who are malingering. We call them malingerers, but it's not a proper word. I mean, they are not liars. Their visual acuity is reduced because of certain mental status. Right? They are not lying. Children can't lie. Children don't lie. So if they say they can't see, we as medical professionals, we have to find out why they can't see. So this is a good way of ruling out hidden refractive errors in children who complain reduced vision. We usually call them malingerers, but the correct word is non-organic visual loss, because they don't have, their vision is reduced, right? But there are certain ways of knowing that there's no organic, there's no proper pathology, there's no eye pathology, there's no refractive error, there's no brain or neurological problem. So they are not lying also. Their real reason is something like school stress or domestic problems causing their vision to be diminished not in a physical way. So if the patient has, like I said in Down syndrome patients, it's very important to do cyclorefraction when there are corneal opacities, when there are lens opacities. It's very important. So which drug you use in your practice? Of course, you can use all three drugs: tropicamide, cyclopentolate, and atropine. So if you use, the dilating action of tropicamide is faster. Atropine, it's slower. But it's not actually the dilating effect which is important, it is a cycloplegic effect. So the cycloplegic effect of atropine is very, very strong. Cyclopentolate is something in between, but the action of tropicamide is very weak on cyclopentolate. Although it dilates quick, it does not give proper cycloplegia for you to do refraction. But in our country, we are running low in most things. No IOLs, not even Panadol sometimes in our hospitals. So we keep on requesting these things, but not available, right? So it's very difficult to find a proper cycloplegic drug. So if you are, but tropicamide is available, for some reason it's available, but I can't advise you to use tropicamide as your main cycloplegic agent. But if you are using tropicamide, you have to develop sort of a skill to do it in a proper way, knowing that it has not done the proper cycloplegic effect. So still the accommodation can come. Still, although the pupil is dilated, the lens thickness can change because tropicamide is not very powerful. On the other hand, when you put atropine, it's not pleasant. So doing atropine refraction for all esotropes was the practice some time back. But now I think we are giving up, and we are doing atropine refraction only for very selected cases. So cyclopentolate remains our ideal drug to do cycloplegic refraction. But if you go by pupil dilatation, you will have to keep the patient waited for a long time because it dilates very slowly. But equally, its cycloplegic action also takes longer. And so you put cyclopentolate and keep the patient. So you can't rush. You can't do this in a rush. You have to keep the patient at least 45 minutes, 60 minutes in the waiting room. Try to find some way of keeping them engaged to do your proper cycloplegic refraction. But atropine, one advantage is you can prescribe atropine to use at home and come back on a different day. So the patient does not have to wait in the clinic. You can simply give the prescription, but the effect of cycloplegia can last up to few weeks. So if you use atropine in an older child, that child will not be able to go out, will not be able to study, will not be able to play for at least for a couple of weeks properly. So it's not pleasant in all the kids, all the children. It's not very pleasant. So these are the advantages and disadvantages of using these drugs. So depending on the availability, that's the main deciding factor in our country at the moment. What is available, we use that. So at LRH, honestly, we are using tropicamide. So can't help, right? But we keep cyclopentolate as a reserve. Please don't quote me and put tropicamide as your default drug because it's not available. Only we are using it. We are requesting but not getting it. What can we do? So atropine is available, but for the reason I told you, because you have to get down the patient twice to the clinic. It's not easy for, suppose now it's a child and parents have to put leave on 2 days to bring the child to the clinic. Our clinic numbers will go up, our workload in the clinic will go up. So it will be duplicate of our work to use atropine. And once you use the atropine, while you have to throw it away, you can't use for several people, and it's a waste of drugs. So all these things come into play in deciding which drug to use. So if you are using tropicamide, please use wisely. Right? I can't say to use it or not to use it, but you have to be mindful about the disadvantages of tropicamide. But if you have cyclopentolate, that is perfect. So the next question is, now we do a perfect cycloplegic refraction. When are we going to prescribe glass? Are we going to prescribe or not? Two key questions go in my mind when I see the refraction. So is it, so shall I prescribe to prevent or treat amblyopia? Or if this child has a squint, is it important? If I prescribe glasses, is it going to help in managing this squint? This is American Academy Guideline. So each year I come and show this to you, but each year we are it's not going to practice. So this may be little, our threshold is much lower to prescribe glasses actually. But I think we can increase our threshold, our tendency to prescribe glasses, we can change according to this. You can see smaller kids can tolerate higher refractive errors. Right? You don't have to be in a hurry to give glasses to children, particularly very, very small children. Right? So if the story changes if they have a squint, particularly esotropes, right? So hypermetropia in a child who is less than 1 year, you can wait even +6, right, if the child is otherwise normal. Right? This is freely available in American Academy website. Right? This is not something that I have created, I have copied it. But if the child has esotropia, you have to consider whether this is early onset accommodative esotropia. And if it is so, then you have to prescribe anything above 2 +2 or +3. Of course, astigmatism causes more amblyopia than anything else. Right? More than myopia, more than hypermetropia. Remember, this is isometropia. That is, if the refractive error is almost equal in both eyes. In school-going children, the tolerance should come down. You should think about prescribing more. Right? Even the smaller errors become very significant. So anisometropia is even more amblyogenic than other refractive errors. So, but again, in very small kids, in 2-year-old kids, even -3 astigmatism, even -3 myopia, you can tolerate difference between the two eyes. Right? So, you should not be in a hurry to prescribe glasses to children particularly children without squints. You can always re-refract them, right? If you prescribe them unwanted glasses, they will not wear anyway. They will not use it anyway, right? They will just throw it away. So there will be a huge fight at home, right? Some parents have gone to the extent of, marital problems when you prescribe inappropriate glasses. So mother and father, huge argument, right? Then fights at home. So you can avoid all that by thinking twice before prescribing glasses. Of course, you have to prescribe when it is necessary, but when you prescribe, we should fit into some sort of guideline. So few cases where we have to come into consensus in managing. So this is a familiar situation for all of you. 6-month-old baby is brought to you. Mother says there's no squint at birth, but squint starts around 3 months of age. This is a full-term baby. Baby is otherwise well, nice baby. And just check the Hirschberg test. You find 30 prism diopter alternating ISO, or maybe even more. And obviously there's no nystagmus, and you measure visual acuity, which is normal, pupils normal, anterior segment normal, and the eye movements also. Mostly you check what you need to know is whether abduction is normal or not in this kid. Abduction is essentially normal, and the eye surgeon checks the fundus, that is also normal, and you put cyclopentolate and do the cyclogic refraction, comes like this. So your working distance is essentially 1.5. So what is your diagnosis? Who is going to prescribe glasses for this child? Okay, nobody. Yeah, so this is infantile esotropia, right? So this diagnosis is clear cut. It's typical. So management of infantile esotropia is not, there's no doubt, there's nothing hidden, nothing subtle. It's clearly documented. So you do a surgery or Botox injection. So in my practice, I do surgery if the angle is too large, and I consider giving Botox injection if the angle is smaller. So idea is to restore the alignment and allow child to develop binocular vision. Right? You are not going to make the child perfect, because we are anyway going to leave some amount of esotropia, and later on child can develop inferior oblique overactions, DVDs, and this child has to be long-term follow-up, frequent refractions, things like that. In the clinic, you can't discharge this child, right? So we are not making them perfect. We are giving them the best chance of developing the vision during the first year of life. So this case, I don't know whether you are familiar with, but at LRH, we are very familiar. 6 months old baby, again, now this is a squint from birth. Child had problems at birth. This child also has 30 prism diopter ISO. But the child is not fixing properly. So you can't actually check the eye movement. So you check the doll's eye movements, and you see abduction is restricted. When we check the fundus, their optic nerves are not healthy because the child had neonatal problems. When you do refraction, like the previous 6 months old baby, it's like this. So who is going to prescribe glasses for this child? Nobody. Thank you. So this is neurological, right? No point giving glasses. This child also, if you give glasses, it's inappropriate. So what is the diagnosis? This is 6 nerve palsy. Right? And the child has obvious cortical visual impairment. So a child has to, child is already on neurology follow-up. So we can advise on visual stimulation, and we align the eyes when the child is medically stable. And if the squint is stable, again, you can consider doing surgery or Botox injection, but it has to be a surgical management. Until you do surgery, you have to follow up with visual stimulation, things like that. Another case, 3-year-old boy, this is a sudden onset, like parents have noted, sudden onset squint over a few days. Child is otherwise normal, going to school, everything okay, and you see large ISO in one eye. Yeah, visual acuity is also normal, right? Abduction is normal, fundus normal. You do cyclo refraction, so it's like this. Working distance is like this. So what is your diagnosis? So still I don't have a diagnosis. I have a differential diagnosis only. It could be early 6 nerve palsy, although I said abduction is normal. It could be early 6 nerve palsy. This is what I am really scared of. Oh, the umbrella term is acute non-accommodative concomitant esotropia. Right? This is not. This entity is not 6 nerve palsy. I mean, once you exclude 6 nerve palsy, only you can come into this diagnosis. Or it could be accommodative esotropia. Or sometimes even untreated infantile esotropia present like this. So what you do is you get down all the photos and see, and child's first year birthday, 6 months, at 6 months photos, the squint is there, right? Only thing is parents have not noted, or they are lying, or I don't know. So these infantile esotropia are still present like this. But this child needs investigations. What I do is I repeat cyclopedic refraction. Maybe I go ahead with atropine refraction in this child because I definitely need to know whether this is accommodative esotropia. Of course, most of these children I end up doing imaging. I don't want to miss a brain tumor. Although there's no, although my orthoptist says there's no 6 nerve palsy, but I end up doing scans in these children, at least a CT scan. And I asked a pediatrician to have a look, neurologist, pediatric neurologist, which is very helpful. Their opinion, their backup is very important because you don't want to miss a brain tumor in these children. So acute non-accommodative concomitant esotropia, that is not the cases which are acute onset but not 6 nerve palsy. So how do you manage? we have to start patching immediately because they are squinting only one eye. The child is very young, can develop amblyopia within few weeks. So you have to start patching from day one, whatever the etiology. And so basically you have repeated your cyclo refraction and you know it's not accommodative esotropia. And if there's no spontaneous resolution, we have to plan for surgery or Botox injection. Another familiar case, 3-year-old girl. This just for completion of this talk. So this is a more gradual onset. Sorry, this is not weeks, this is months. This should be months. Another normally, neurologically normal child, about 20% diopter, alternating ESO, no nystagmus, but the visual acuity is reduced. Again, there's no 6-nerve palsy, fundus is normal. When you do cycloplegic refraction, there is hypermetropia, obviously. Right? For a 3-year-old, this is definitely, this hypermetropia is too much. So orthoptics is very, very critical in this patient because I need to know what is the diagnosis. Without a diagnosis, we can't proceed. We can't just try, plastic ak dila balamuda, bifocal ekak dila balamuda. You can't manage patient like that. You have to know what you are managing, right? If you are managing a 6-nerve palsy, you have to know that is a neurosurgical problem. So if you know if it is a refractive accommodative esotropia, what to prescribe? If it is a high ACO ratio accommodative esotropia, what to prescribe? If it is a partially accommodative esotropia, what to prescribe? So diagnosis is very, very important. So remember, alternating esotropia is not a diagnosis. So these are the proper diagnoses that you have to come into, that we have to get together and come into for proper patient management. Earlier I described one diagnosis, that is infantile esotropia. Then these are the other very, very important esotrope subgroups that we have to come into a proper diagnosis for proper patient management. So what are the similarities and differences in these 3 subgroups? Of course, refractive accommodative esotropia, right? It is the underlying problem is uncorrected hypermetropia. Right? So the child needs hypermetropic correction. So their refractive error is much higher. High ACO ratio accommodative esotropes, their refractive error is much lower. So refractive accommodative esotropes need single vision hypermetropic glasses, and we try to wean the power off over the years. ACO ratio patients, they need bifocals, flat top bifocals. And the other group is partially accommodative esotropes. They need single vision hypermetrop glasses. And they are at a very high risk of developing amblyopia than other groups. And they need surgery at some point down the line when the angle is stable. Okay, so I think that's it for me. Any questions? Anything you want to know?
Case number 2.
Yeah.
When you said the onset was at 3 years, and then you recommended because of partial amblyopia, occlusion. What kind of occlusion would you give, and how often would you be able to see the child?
Occlusion.
Yeah, that case number 2. This one.
Yeah, I don't think I spoke about occlusion here.
The 3-year, case number. You said the parents may not have noticed it, but it's only 3 years.
Yeah, sorry, yeah.
This one.
Yeah.
Case 3.
Yeah. Yeah, this one, because it's a unilateral case, yeah, you have to start occlusion until, you have to continue occlusion.
Yes, sir.
Yeah.
But first, is total occlusion or, like.
Yeah, like 2 hours, yeah. because mainly because the accurate visual acuity measurement is not possible at this age group. So you undermine your amblyopia measure, your diagnosis of amblyopia may not be correct at this age. So I mean, this child is anyway going to develop amblyopia if you don't start occlusion soon. Until you come at your definitive treatment like surgery or spontaneous resolution of this squint, you have to prescribe occlusion. Yeah. Okay. Okay. Thank you very much.